Welcome, everyone. Today, we're going to be diving deep into COPD.
That's chronic obstructive pulmonary disease, by the way.
Yeah, exactly. COPD. You all have sent in some seriously interesting research and notes on this.
Really fascinating stuff.
Yeah, I'm excited to dig into it with you. By the end of this, you'll know way more about COPD, like what causes it, the risks.
And even some of the newest ways to treat it.
Right. So, to kick things off, what exactly is COPD?
It's easiest to think of it as like a bunch of lung diseases all kind of working together to make it hard to breathe.
Okay.
The GOLD, the Global Initiative for Chronic Obstructive Lung Disease, they're the ones who make the official definition.
Okay.
It gets a bit technical, but basically they say COPD is when airflow is limited and can't be totally reversed.
So, like, the damage to the lungs is permanent.
Sadly, yeah. And to make it even trickier, COPD isn't just one disease. It's more like a blanket term for different conditions that affect the lungs.
Okay, so let's break that down a little bit. What are these conditions?
Well, there's emphysema. That's where the little air sacs, the alveoli, get damaged. They
Wow.
lose their shape, can't bounce back like they should, and they get bigger. And that makes it hard for them to exchange oxygen and carbon dioxide.
So those tiny sacs, they're essential for breathing, obviously.
Exactly. That's why emphysema makes it so hard to catch your breath.
Makes sense.
Then there's chronic bronchitis. It's more intense than just a smoker's cough. It's like constant irritation and inflammation in the airways. So you're always coughing, producing lots of phlegm.
Not fun at all.
No, definitely not. And then the third one, we've got small airways disease. This one targets the tiny bronchioles, those little branches off the main airways,
Okay.
and they get narrowed. Makes it super hard to breathe, like trying to breathe through a straw.
So basically, with all three of these, it's just tough to get air in and out of the lungs, right?
Right, that's the main problem. And what's really concerning is how common COPD is. It's the fourth leading cause of death in the US right now, and it's expected to be the third globally by 2020.
Oh, wow. That's really scary. So let's get into what causes this whole complex disease. And I think we all know the biggest culprit here.
Smoking, right.
Yeah.
Yeah, no escaping that. Cigarettes are a huge cause of COPD. All those chemicals, they just irritate and inflame the lungs. And then all those changes we talked about, they start happening.
Right. And one of the studies you sent me, they actually measured smoking intensity in pack years, which I thought was kind of interesting. Could you explain that a bit?
Sure, pack years. It's basically a way to measure how much someone smoked in their life.
Mm-hmm.
So you take the packs of cigarettes they smoke per day, multiply that by the number of years they've been smoking.
So if someone smoked a pack a day for like
Yeah.
20 years, that'd be 20 pack years.
Exactly. And the higher that number is, the higher the risk of COPD, and the faster their lungs tend to decline.
Yeah, that makes sense. The more you're exposed, the more damage. Right. But what I found interesting was that the study also said that pack years only account for about 15% of the difference in lung function. So what's going on there?
That's the intriguing part. It basically tells us that smoking, as big of a factor as it is, isn't the only thing at play.
Right.
There must be other factors, like our genes or things in the environment, maybe even a combo of both.
Which explains why you see some lifelong smokers who never get COPD.
Right.
And then others who've never smoked end up with it.
It's a whole mix of things, and researchers are still trying to figure it all out.
So it's not as black and white as if you smoke, you get COPD, which is good to know.
Exactly.
So what are some of these other risk factors, things people might not even realize?
Well, one is airway responsiveness, basically how easily your airways narrow when they get irritated.
Okay.
It's a big thing in asthma, but research is suggesting it could be involved in COPD too.
I remember reading something about the Dutch hypothesis and the British hypothesis, something to do with that, right?
Yeah, those are two sides of a big debate in the medical world. The Dutch hypothesis says asthma and COPD might just be different versions of the same underlying problem. The British hypothesis, though, sees them as totally separate, different causes, different everything.
Interesting. So there's still a lot we don't know about how those two are connected.
Exactly. And figuring that out could mean a lot for how we treat and prevent both conditions.
Right. So what other risk factors are we talking about?
Well, respiratory infections are a big one. They don't cause COPD, but they can definitely worsen it.
Yeah, if your lungs are already struggling, an infection would be awful.
For sure. Then there's your job. Some jobs, even if you don't smoke, put you at a higher risk.
What?
Jobs with lots of dust, fumes, chemicals, stuff like mining or working with certain textiles.
So it's not just your personal habits, but also your work environment.
Right. And then there's air pollution. If you live somewhere with bad air, you might have more breathing problems, which could lead to COPD.
Right.
Yeah.
And of course, we can't forget secondhand smoke.
Especially bad for kids. Developing lungs just can't handle that.
So the bottom line is smoking is huge, but it's not the only thing to worry about with COPD. It's good for people to be aware of these other things.
Absolutely. It helps people make better choices, protect their lungs.
You mentioned genetics earlier.
Yeah.
How much does our DNA actually play a role in COPD?
This is where things get super interesting. We know for sure that genes are involved because of alpha-1 antitrypsin deficiency.
I've never heard of that one. What is it?
Well, alpha-1 antitrypsin, or AAT, it's a protein, helps protect your lungs from damage.
Okay.
If you have a severe deficiency, like your genes just don't make enough of it, you have a really high risk of COPD. And they usually get it much younger than you normally see.
So even if you never touch a cigarette, your genes can set you up for lung problems.
Exactly. AT deficiency is a prime example of that. And it's not the only one. There are other genes that could be involved.
Really?
Yeah, research is constantly finding new ones.
So we've got the causes, the risk factors, all that. Now, what about how COPD actually progresses over time? It's chronic, right? But how does that affect your lungs over time?
Imagine a tracking curve. It's basically the path your lung function takes throughout your life.
Okay. How do they track that, though?
Well, they use this measurement called FEV1, forced expiratory volume in 1 second. It's how much air you can force out in one breath.
Okay.
It's a really good way to see how healthy your lungs are.
So if they track that over time, they can see if the lungs are getting worse.
Yep. Research shows that people kind of stay on a certain track based on their genes and environment.
So some people just naturally have better lungs.
Yeah, and some people's lungs might decline faster than others for different reasons.
That really makes you think about how important those early interventions and lifestyle choices are.
It really does. Taking care of your lungs early can make a huge difference in the long run.
So now that we know how it progresses, let's talk about what's actually happening in the lungs. You send over some really in-depth research about those physiological changes. Can you walk us through those?
Sure. So the main thing in COPD is airflow obstruction. Basically, it's hard to get air in and out. Doctors use spirometry to measure that. It's a lung function test.
Yeah.
It measures stuff like FEV1, which we talked about, and also FVC, which is forced vital capacity.
What's that?
It's the total amount of air you can breathe out forcefully after taking a big breath.
Okay.
It gives you an idea of your overall lung capacity. Doctors use both FEV1 and FVC to see how bad the airflow obstruction is.
So if those numbers are low, it means there are a lot of obstruction.
Yep. And another big change is hyperinflation. Your lungs get overinflated and trap air inside.
It's like a balloon that you blow up too much and it loses its stretchiness.
Perfect analogy. At first, hyperinflation actually helps to compensate for the blocked airflow, but it ends up making things worse over time. The lungs become less efficient, and it gets even harder to breathe.
So you're working harder to breathe, but you're not getting as much oxygen.
Exactly. And all this affects gas exchange, which is how oxygen gets into your blood and carbon dioxide gets out.
That sounds pretty serious.
It is. It can cause hypoxemia, meaning low blood oxygen. And if it gets really bad, it can even cause hypercapnia, which is too much carbon dioxide in the blood.
That can be life-threatening, right?
Yeah, especially in severe COPD cases.
You also sent me some research about the pathology of COPD, which I think means what's going on at a microscopic level in the lungs. Can you talk a bit about that?
Of course. So one of the first things that happen is changes in the large airways. The mucus glands get bigger and you see more goblet cells.
Okay.
Those are the cells that make mucus.
So that's where all that phlegm and coughing comes from.
Exactly. But the real damage is in the small airways. They get inflamed, narrowed, and damaged, making it even harder to breathe, like trying to breathe through a bunch of tiny, clogged up straws.
That sounds incredibly uncomfortable.
It is. And then there's damage to the lung parenchyma, the lung tissue itself.
And that's where emphysema comes in, right?
Right. Emphysema is the destruction of those little air sacs we talked about earlier.
Yeah.
And just to make things more complicated, there are different types of emphysema.
Oh. What are the different types?
Well, the most common one linked to smoking is called centriacinar emphysema. It usually starts in the upper part of the lungs.
Okay. And the other type?
It's called canicinar emphysema, and it's often seen with alpha-1 antitrypsin deficiency. It usually affects the lower parts of the lungs.
So even within emphysema, there are variations depending on the cause and where in the lungs it affects.
Exactly. COPD is really complex with a lot of nuances.
So we've talked about smoking, genetics, environment, all contributing to COPD. But how do all these factors actually cause the disease? It seems like such a complicated chain reaction.
It is, but let me try to simplify it a bit. It all starts with inflammation. Cigarette smoke triggers an inflammatory response in the lungs, which attracts white blood cells that release these damaging enzymes.
So it's like your body is attacking itself.
In a way, yes. Those enzymes start breaking down the structure of the lungs, including a protein called elastin.
Okay.
Elastin is what allows the lungs to stretch and recoil properly.
So they lose their elasticity.
Exactly. And as this damage continues, cells start to die off. The body tries to repair the damage, but it just can't keep up. And that's what leads to that progressive loss of lung function you see in COPD.
One of the studies you sent over mentioned the elastase-anti-elastase hypothesis. What is that exactly?
That's a really important theory for understanding how COPD develops. Elastases are those damaging enzymes that break down elastin, and anti-elastases are the good guys trying to keep those elastases in check.
So it's like a battle going on in the lungs.
Exactly, and smoking tips the scales in favor of the elastases.
And if you have those genetic predispositions, you're even more vulnerable.
Exactly. It's this complex interplay of factors that determines how COPD develops and progresses.
Wow, it's complicated. Okay, so now I want to talk about what COPD is like to actually live with. I mean, it's more than just shortness of breath, right?
Oh, absolutely. COPD affects every part of your life. And the symptoms, they tend to creep up on you.
So it's easy to ignore them at first, especially if you're used to coughing from smoking.
That's right. But it's so important to pay attention to any changes in your breathing, coughing, energy levels.
So you're saying be really aware of what's going on with your body.
Exactly. The most common symptoms are that persistent cough, producing phlegm, and shortness of breath, especially when you're active.
And that shortness of breath, that really limits what you can do.
It really does. As it gets worse, even simple things like going upstairs or doing chores become really hard.
Right.
And you'll have more exacerbations, those sudden flare-ups when your symptoms get much worse.
Oh, that sounds awful.
They are.
Yeah.
And in the later stages, people often need supplemental oxygen all the time because their blood oxygen just stays too low.
So COPD really has a huge impact on your quality of life.
It can, unfortunately, but with the right management and support, people can still live full lives with COPD.
So let's say someone goes to the doctor because they're worried about their breathing. What are the main things doctors look for to diagnose and assess COPD?
The most important tool is spirometry, that lung function test we talked about. It measures those key values like FEV1 and FVC so they can see how severe the obstruction is.
So it's not just listening to your lungs with a stethoscope.
Right, spirometry is much more precise. They might also do other tests to get a fuller picture.
Like what?
Things like lung volume measurements to check for hyperinflation. They might measure diffusing capacity, which tells them how well your lungs transfer oxygen into the blood. And arterial blood gases, which measure your blood oxygen and carbon dioxide levels.
And imaging tests, like X-rays or CT scans.
Yeah, those can be helpful to visualize the lungs, see if there are signs of emphysema, and rule out other lung problems.
Right. And for younger folks, or if there's a family history, they might test for that alpha-1 antitrypsin deficiency.
Exactly. It's all about getting a good, thorough evaluation to figure out the best way to treat it.
Okay, so we've learned all this about COPD. What can people actually do about it? Is there any hope?
There's definitely hope. We might not have a cure for COPD, but we can do a lot to manage the symptoms, slow it down, and help people live better.
That's good to hear. So what are some of the options?
The most important thing, hands down, is to quit smoking.
Even if you've smoked for years and years.
It's never too late. Quitting can seriously slow down the damage.
That's powerful. What about medications? Can they help?
Oh, for sure. Bronchodilators are like a cornerstone of COPD treatment. They relax and open up the airways.
So they help you breathe easier right away.
Exactly. And then there are inhaled corticosteroids. They help to reduce inflammation in the airways.
So more of a long-term approach to control inflammation.
Right. And if your blood oxygen levels are always low, oxygen therapy can be a lifesaver.
It sounds like there are lots of different meds that can help.
Yep. And doctors work with their patients to find the right combo to control their specific symptoms.
But it's not just about meds, right? What about lifestyle changes?
Those are crucial too. One of the best things you can do is pulmonary rehabilitation.
What's that?
It's a whole program that combines exercise, education, and breathing techniques to help people manage their COPD and feel better overall.
Ah, so it's like a holistic approach.
Exactly. It's about giving people the power to take control of their health and live their best life despite COPD.
Love that. The research you sent also mentioned more specialized treatments. Can you talk about those?
Sure, for some people with severe emphysema, there's a procedure called lung volume reduction surgery.
Okay.
They actually remove damaged lung tissue, which lets the healthier parts work better.
So it's like giving the good parts of the lungs more space to work.
Exactly. And in the most severe cases, lung transplantation can save lives.
Wow. So many different options. Sounds like there's something for every stage of COPD.
There is. And the key is to talk openly with your doctor. Figure out what's best for you.
Well, we've covered a lot today, but we're going to take a quick break before we move on to the next part of our COPD deep dive. Stay tuned. We've been talking a lot about the science behind COPD, but, I kind of want to shift gears a bit, talk more about, like, the human side of things, what it's actually like to live with this disease.
Yeah, that's so important. COPD, it's not just a physical condition. It affects people emotionally, mentally, too.
It makes sense.
Yeah.
I mean, if you're struggling to breathe, can't do the things you used to enjoy, plus the worry of what's going to happen, that's got to be stressful.
Absolutely. Anxiety and depression, they're pretty common with COPD. Imagine, simple everyday things becoming a struggle, like your body's not cooperating anymore.
Yeah, that must be really isolating, scary even. So it's not enough to just treat the physical symptoms. Got to think about mental health too, right?
Definitely. Got to take a whole person approach to caring for COPD, and that's where self-management comes in.
Yeah, I saw that term a lot in the research. What does that actually mean for someone with COPD?
It's about empowering people to, take charge of their condition.
Yeah.
It's not just following the doctor's orders. It's about really understanding your disease,
Uh-huh.
knowing your triggers, and making smart choices for your health.
So becoming like an expert in your own body, how COPD affects you personally.
Yeah, that's a great way to put it. It's working with your healthcare team, of course, but also taking ownership of your own health.
Okay, so what are some things people with COPD can do to actually self-manage?
Lots of things. Monitoring your symptoms every day is key. Noticing any changes in your breathing, your coughing, energy levels.
So pay close attention, catch anything early on.
Exactly. And using your medications the right way, like knowing how and when to use your inhalers, can make a big difference.
Yeah, using those correctly is important. I bet people mess that up sometimes.
It happens. And then there are the broader lifestyle things. Staying active, eating healthy, getting enough sleep.
Stuff we should all be doing anyway. But even more important with COPD, I'm sure.
For sure. And avoiding triggers. If you know that dust, pollen, or smoke makes your breathing worse, do what you can to avoid them.
It sounds like self-management is a mix of knowing the medical stuff, practical skills, and just being really tuned into your own body.
You got it. And there are actually some great resources to help people build those self-management skills. Like pulmonary rehab programs, they often include that kind of education.
So it's more than just exercise. It's really equipping people to deal with COPD in their daily lives.
That's right. And there are support groups, online resources, even apps for people with COPD.
Wow, so there's a whole community out there. One of the studies also mentioned action planning. What's that all about?
Action planning is really helpful. It's basically a structured way to help people set goals, like concrete, measurable ones, and then make a plan to reach those goals.
So being proactive, not just reacting to things as they come up.
Exactly, taking charge. It's about living your best life with COPD, not letting COPD control your life.
I like that. Can you give me an example of how an action plan might work for someone?
Sure, let's say someone wants to be more active. That's a great goal, but it can feel overwhelming with COPD, right?
Yeah.
An action plan breaks it down into smaller steps.
So instead of just saying, I want to exercise more, you'd create a plan with specific activities, a timeline, all that.
Yeah, so maybe the first step is a 5-minute walk 3 times a week. Then slowly increase the distance, how often you walk. The plan would also include things like using your inhaler before you start or pacing yourself so you don't get too out of breath.
It's like a roadmap for getting where you want to be.
That's a great way to put it. And studies have shown that action planning actually helps. People get better at self-management, they're more active, and their symptoms even improve.
That's amazing. Okay, let's switch gears again and talk about the newest stuff happening in COPD research. There's so much going on. One thing you mentioned was biomarkers. Can you explain what those are and why they matter?
Biomarkers are like signals. They give us info about what's happening inside the body. With COPD, researchers are looking for biomarkers that can tell us how someone's COPD might progress,
Oh,
or who's at higher risk of getting really sick, and even how well someone's responding to treatment.
so it's all about getting more personalized info, going beyond just Oh, you have mild COPD or whatever.
Exactly. Instead of just broad categories, biomarkers could help us create treatment plans that are tailored to each person.
That makes sense. So what specific biomarkers are they looking at?
Well, there are a ton, but some of the most promising ones are inflammatory markers, which tell us how much inflammation there is in the lungs. There
Hmm.
are oxidative stress markers, these measure damage from free radicals, and markers of lung damage, which show how much the structure of the lungs has already been affected.
So by looking at all these different markers, doctors can get a much clearer picture of what's happening in each person's lungs.
Exactly. And that could lead to much more targeted and effective treatments in the future.
Speaking of treatments, are there any exciting new therapies in the works for COPD? What's coming down the pipeline?
There's a lot of promising stuff. One area is developing drugs that actually target the specific things that cause COPD.
So instead of just treating symptoms, they're going after the root of the problem.
Exactly. And some of these new drugs are doing really well in trials. Less inflammation, less lung damage, even improving lung function in some cases.
That's incredible. Anything else that's got people excited in the COPD research world?
Oh yeah, stem cell therapy is another big one.
Ah, stem cells. The body's own repair system.
That's it. Scientists are looking at using stem cells to actually regrow damaged lung tissue.
So like rebuilding the lungs from the inside.
That's the goal. It's early days, but the initial results are looking good.
Sounds like the future of COPD treatment is pretty bright. Okay, we're going to take another quick break, but when we come back, we'll wrap up our deep dive into COPD with some final thoughts on key takeaways. All right, we're back for the last part of our deep dive on COPD. We've covered a ton of info, the basics, the research, everything.
It's been quite a journey exploring all things COPD. You know, what's really struck me is just how much we've learned about this disease.
It really is amazing. I mean, we've gone from this simple idea of a smoker's cough to understanding that it's so much more complex. Genes, environment, even down to the cells.
And with that understanding, the treatments have come such a long way. We're not just talking basic inhalers anymore. We have targeted therapies, even surgery.
Yeah, it shows you how powerful research and innovation can be in medicine. One thing that really stuck with me through all this research is this idea of the COPD trajectory. Like everyone's path is a little different.
It's a powerful concept. The idea that everyone with COPD has their own unique journey, shaped by, their genes, environment, the choices they make.
And knowing that early intervention can make such a big difference in how that path unfolds.
That's key. The sooner someone quits smoking, the better their chances of slowing things down.
Right.
And even if someone already has COPD, there are things they can do. Manage their symptoms, have a good quality of life.
It comes back to that idea of empowerment, giving people the knowledge and tools to be in control of their health.
That's what it's all about. Empowering people to live their best life, even with COPD, focusing on what you can do, not what you can't.
I love that. So for anyone listening, if they're worried about their lungs, maybe thinking they might have COPD, what's the most important thing they can do?
Easy, talk to their doctor.
Yeah.
They can assess your risk, do the right tests, and help you come up with a plan that works for you.
And don't be afraid to ask questions. The more you know about your health, the better.
Absolutely. Doctors are there to help you understand and make the right choices for you.
Well, we've covered a lot in this deep dive, but remember, this is just the start of your journey to understanding COPD.
There's always more to learn, and there are new discoveries happening all the time.
So stay curious, stay informed, and be proactive about your health. Your lungs will definitely thank you for it.
Great advice. Knowledge is power, especially when it comes to your health. Can't invest in anything better than that.
This has been the deep dive. We hope this exploration of COPD has been helpful, maybe even empowering for you.
Take care, everyone, and keep those lungs healthy.